Well, good morning. Great to see all of you here today. My name is Anand Parikh. I'm the Chief Medical Advisor here at BPC. I want to welcome all of you to today's event. For those of you who are new to BPC, our mission is to actively seek to combine the best ideas from both political parties to promote health, security, and opportunity for all Americans. We drive principled and politically viable solutions through the power of analysis, negotiation, and advocacy. Today's event is being streamed live online and on C-SPAN 2, and a recording will be available later this week. We invite you to interact with us on Twitter about today's event using the hashtag BPCLive and the handle BPC_Bipartisan. We'll be taking questions after our panel discussion, so if you're watching online and have a question for our panelists or our opening speaker, you can use hashtag BPCLive to ask it, and we'll try to get to those during the question and answer. Over the next 90 minutes this morning, we'll be discussing patient-centered comparative effectiveness research. While that's a mouthful, essentially what our topic will be focusing on today is identifying how best to provide optimal care for patients based on science and based on patient priorities. As a physician for many years, I recall instances and conversations with patients when there was evidence to support a particular course of treatment over another. And I also recall other instances when there was a lack of evidence. Comparative effectiveness research, as you'll hear about today, is important for healthcare providers and patients so they can make the best treatment choices together. We call this shared decision-making, and comparative effectiveness research is central to it. Today's forum is the first of two educational forums BPC plans to host on this topic. This morning, we hope to learn how and why this research is conducted, how the results are used by patients, healthcare providers, and other stakeholders, and how this process is currently funded. Our second forum will delve deeper into the future scope and direction of comparative effectiveness research and its role in improving outcomes and its effects on healthcare spending, though I'm sure the panel will likely touch on this as well today. We're honored to be hosting a fantastic group of speakers and leaders from the public and private sectors. We're also thrilled to have a patient joining us today to provide her thoughts on this very important topic. So without further ado, let me start by introducing Dr. Jody Siegel, who will be our opening speaker. You have Jody's bio in front of you. She is a professor of medicine at Johns Hopkins University, a national expert on comparative effectiveness research, and she'll help us by providing an overview of our topic today. This will be followed by a moderated discussion with our panel and then a discussion with all of you. Thank you. Jody?
Fine. Great. Thank you. Thank you very much for the invitation to be here today, to join you and to teach a little bit about this important topic before we hear from the panel of experts. I aim for you to understand the goals of comparative effectiveness research, what we hope to accomplish with this type of research, and where it fits into the translational research pathway. As is fitting for patient-centered research, let's start with the patient. So some of you may have asked this question to your doctors. Doctor, should I be taking aspirin to prevent a heart attack? I know that I have some worrisome risk factors. Should I? Clearly, as clinicians, we all want to get the right treatment to the right patient at the right time. Comparative effectiveness research generates the evidence to inform the decisions that we make as clinicians, that are made as payers, and that patients make. I want to just start verbatim with the definition of comparative effectiveness research from the Institute of Medicine in 2009. Comparative effectiveness research is the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor a clinical condition or to improve the delivery of care. The purpose of CER is to assist all stakeholders, clinicians, consumers, purchasers, and policymakers to make informed decisions, and that's underlined. This is about making decisions that will improve healthcare both at the individual and population levels. So what are these questions that we need to make decisions about? What do patients want to know? Should I take aspirin? Should I start mammography now at age 40? Should I have my cancerous prostate removed, or will I be safe just waiting a bit? Should I take warfarin, or should I take one of the newer anticoagulants to treat my blood clot? What do doctors want to know? Certainly many of the same things that patients want to know, but also, should I use the robot in this hysterectomy, or should I use the usual open procedure? Should I recommend to my patients colonoscopy, or are the new DNA-based stool cards adequate? Are the new medicines for diabetes better than metformin, which I always prescribe? What does Medicare or other payers want to know? Should we cover implantable defibrillators? Should we cover home care services after a hip replacement? How often should we cover geriatrician visits for residents in nursing homes? So let's take a look at where comparative effectiveness research is on the translational research pathway. So a lot of people think of translational pathways sort of moving left to right. Basic research is research that understands the mechanism of disease, the chemistry, the biology, the physiology, the genetics of how disease occurs. Clinical research is often early testing in humans, testing treatments and devices to see if it's efficacious and if it's safe in humans. Population-based research is often testing interventions that are delivered at a population level, like access to healthy food, access to environments for exercise. And health services research studies the healthcare delivery system. What's the best way to deliver care? Then even further to the right on this picture, I would put dissemination and implementation research. What's the best way to actually get evidence into the hands of the people who need to implement the evidence? What's the best way to get the information to doctors or to payers? So I would put comparative effectiveness research to the right of the translational pathway. The population-based, the clinical comparative research, the health services research, and certainly the dissemination and implementation research. Why is this sort of research important? Many important healthcare decisions really have little scientific evidence, and it's sorry to say that, and it's certainly improving over the past 30 years, but we still make lots of clinical decisions based on expert opinion or tradition, or I just think this is what's best for my patient. Certainly the quality and value of a lot of the care that we deliver is uncertain. There's a lot of variation in practice regionally across the country, so you have to assume that some of that care that's delivered isn't benefiting patients. There are tremendous economic implications of rising healthcare costs, new and very expensive treatments and diagnostic tests that very rapidly diffuse into practice, perhaps before there's adequate evidence to suggest that it's really useful for the whole population in whom it's used. And there's slow translation into practice of evidence-based practices. Some things we actually know what to do, but it's hard to get that into practice. So what should be studied? The Institute of Medicine in 2009 was tasked with considering priorities for comparative effectiveness research. The IOM panel, a small panel, solicited a lot of input and then prioritized 100 research questions into 4 quartiles. Here's an example of a few. I'll highlight some. So one is compare the effectiveness of management strategies for ductal carcinoma in situ, early stage breast cancer. Another is establish a registry to compare the effectiveness of treatment strategies for low back pain. So you can imagine that these answer questions that are very important to clinicians and to patients. In fact, among the 100 top priorities, half of them were about healthcare delivery systems, which I think was a little surprising to a lot of people, but emphasizing that Certainly, understanding health services research is part of comparative effectiveness research. Who funds this type of research? So a lot of different funders have some part in comparative effectiveness research to varying degrees. I want to highlight two that probably do the bulk of funding of comparative effectiveness research, and that would be the Agency for Healthcare Research and Quality since 1999. It's the only federal agency with the sole purpose of producing evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. AHRQ is also committed to training the next generation of researchers, including comparative effectiveness researchers. The Patient-Centered Outcomes Research Institute, since 2010, funds research that will help patients to choose the treatment options that best meet their needs. So they fund research that advances the quality and relevance of evidence about how disease can be effectively diagnosed, treated, and monitored. Now, this isn't to say that others don't also fund this sort of research, but these agencies have this as their primary mission. Let me highlight just a little bit of comparative effectiveness research so that you can get the flavor of comparative effectiveness research and see its impact. This is a fairly well-known example from Dr. Peter Pronovost, my colleague at Hopkins. So ARC invested in his CUSP, the Comprehensive Unit-Based Safety Initiatives, in 2003. So Dr. Pronovost asked, is there a better way to prevent central line infections than what we're currently doing? Central line, big catheter in the neck to give fluids and food and medicine. So this program, in its first 18 months, saved 1,500 lives and nearly $200 million just in Michigan. And the intervention was a very systematized checklist of processes that should happen before a central line is placed and while a central line is placed. So a very low-tech intervention that was highly impactful. And now more than 1,100 hospitals and 1,800 CUSP teams have participated in initiatives like this. And now CUSP teams have spread out to do other things besides prevent central line infections. The evidence-based practice centers funded by AHRQ have produced more than 500 comprehensive systematic literature reviews. And these literature reviews are used as the evidence to support the U.S. Preventative Services Task Force recommendations. They're used to support professional society guidelines like American College of Physicians. They're used to inform the NIH consensus conferences and even inform CMS coverage decisions. Just a couple examples. This is about treating symptoms of diabetic peripheral neuropathy, decision aids for cancer screening and treatment, treatment of non-metastatic muscle-invasive bladder cancer. And as I said, these comprehensive reviews are then used as guidelines. This came out just this month. These are guidelines about non-invasive treatments for low back pain. Whoops, sorry. These are the U.S. Preventative Services Task Force recommendations about screening for colon cancer. And this is about treatment and management of gout. Again, these are all based on the systematic reviews funded by AHRQ. So let me just pause for a moment to talk about the key methodologies that we use. So we talked some about evidence synthesis. So that's taking the evidence that exists in the literature and comprehensively synthesizing it so that it's useful. Certainly, though, we also do evidence generation, so making new evidence. And sometimes this uses experimental methods like trials, but sometimes it uses observational methods, so using existing data, like data from the patient's electronic health record, or data from the administrative claims, the billing data from patients, and applying very rigorous and sometimes complex methods to really glean evidence from this sort of data. Stakeholder engagement methods are part of CER, as are the dissemination and implementation methods. Other examples of important results for medical practice includes a study from the VA's Surgical Improvement Program. So these researchers asked, is bariatric surgery, weight loss surgery, more effective at preventing deaths than usual care, which is no surgery, in morbidly obese veterans. So they identified 2,500 veterans, mostly men, who had had bariatric surgery and compared them to similar patients who had not had bariatric surgery. And as these lines show, they diverge, so that the surgical patients had much lower rates of mortality over the 12 years of follow-up than the non-surgically treated patients. So rigorously done, and certainly informs a question suggesting perhaps bariatric surgery is appropriate for these patients. Another is funded by PCORI. This is about intravenous versus oral antibiotics for children with bone infections after hospital discharge. So they asked, are oral antibiotics as good as intravenous antibiotics? And yes, children treated with antibiotics did not have more treatment failures than those treated with antibiotics intravenously, and it was much more satisfying to the patients and to the parents and had fewer trips to the emergency room for complications of their catheters. So that was a trial. That was a pragmatic trial. So it was a trial that was conducted in the usual care settings of these patients. PCORI, Patient-Centered Outcomes Research Institute, has made major advances in establishing networks for the conduct of pragmatic clinical trials. So remember, these are different than the trials that are conducted by perhaps drug companies that are very tightly controlled and the patients all look alike and everybody gets very tight follow-up. No, these are trials that are conducted in the patient's usual care setting when they're cared for by their usual doctors or surgeons. So PCORI has set up PCORNet with clinical data research networks, which are networks of health systems, and patient-powered research networks, which are really driven by patients. So for an example, Johns Hopkins is part of the PATH clinical network, which is other health systems in Pennsylvania and in Utah. So the first trial that PathNet is involved in is answering this question: what's the best dose of aspirin to prevent heart attacks and stroke? And it's hard to believe that this question has not been answered because aspirin's been used since the 1990s for stroke prevention. Should patients get 81 milligrams, baby aspirin, or should they get 325 milligrams of aspirin? So this is a big trial embedded in the usual healthcare system, should enroll, I believe, 20,000 patients across these 6 sites, 6 health systems. So what outcomes are important when we conduct CER? So this is patient-centered research. So therefore, the outcomes that we look at should be important to patients. Now, clinical trials often don't measure outcomes that are important to patients. They may be important to the FDA if they're approving a product and saying that it's efficacious and safe, but they're not always that relevant to patients. So patient-centered outcome measures are measures that assess the impact of the disease and its treatment on patients. So for example, pain, a very patient-relevant outcome. Patients don't want pain. Depression, and there's lots of different measures and scales that have been validated to measure outcomes that are important to patients, like the Hamilton Rating Scale for depression. Others might be survival, or out-of-pocket costs, or even time to return to work after an intervention. The NIH has gathered patient-reported outcomes and has a long list and catalog of validated measures of patient-reported outcomes so that researchers can access these tools in order to measure these outcomes. So, aspirin? Well, let me find the evidence. I might go to AHRQ's National Guideline Clearinghouse, which is a store of guidelines. Oh, good, there's one. Aspirin use for the primary prevention of cardiovascular disease. Oh, and in fact, that guideline was based on a systematic review funded by AHRQ in 2015. And in fact, that review became the U.S. Preventative Services Task Force background for their recommendations. So for my man patient, I would say, There's B-level evidence. Yes, I think you will benefit from use of aspirin to prevent heart attack and stroke. For my older woman patient, I would say the evidence is unclear. There's not strong evidence. Let's talk about this. I'm not sure which way to go. I want to just finish by saying this isn't exactly new. CER and CER-type research has been described in the literature since the 1950s, comparing different cough medicines. And in fact, pragmatic trials were first described in the late 1960s by French epidemiologists, but really didn't gain focus until the past decade. The VA has been doing health services research certainly since the 1970s, but growing attention to CER in the 1980s, with appreciation for what is evidence and certainly the rising healthcare costs. The establishment of ARC in 1999 and then PCORI more recently really has focused the funding on CER and has done a lot to advance the methodologies that we use to do this sort of research. So I do think CER is now recognized as an essential late part of the translational pathway to improved patient outcomes, hopefully in a sustainable healthcare system. Thank you for your attention.